So this is David Fairchild. So I'm up next. I'm a director at BDC Advisors, which is a healthcare consulting firm. And I'm also a practicing physician and see patients as well. And I'm going to talk to you a little bit differently about, now that we've heard some of the trends that are happening in 2018, I wanted to talk to you a little bit about some of the value-based care transformation trends. So thinking about it, more from the provider point of view and what seems to be, what people are doing out there across the country. All right. So just quickly, I'll be touching and moving a little bit more quickly than my colleagues here. So I have more slides, and you'll be able to look at them afterwards if you want to as well. I'm going to touch a little bit on value creation. We talk a lot about it in healthcare, and I think so far, if you talk to most physicians, they feel like it's been challenging for the healthcare reform efforts to really create value. And why has that been? So, and I think that there are some trends that are encouraging, and so I'll touch on three basic trends, sort of the incremental evolution of our value-based reimbursement system, from volume to value, and I'll give a couple of examples. I'll talk a little bit about some of the things that are happening that I think are in response to this consumerism that's been mentioned in the marketplace, trying to create more convenient and low-cost care. And then lastly, one of the themes that was echoed already, this idea of moving beyond sort of what I call lip service for patient-centered care. I think the environment is really starting to get serious finally. So interestingly, this just came out. I think a lot of you are familiar with the J.P. Morgan Healthcare Conference that happens every year, and this is just a rundown that was provided by Becker's Hospital Review of some of the top trends or themes from that conference. And it's interesting, if you go all the way to the bottom there, number 12 is deliver value. And in a lot of ways, I feel like value should be up at the top, and that if you can deliver value, the rest of this will follow. So why is that? I think, again, it's emblematic of the fact that it's been difficult so far, despite all the efforts to really create value. And I'm reminded of this quote from Albert Einstein: if I had an hour to solve a problem, I'd spend 55 minutes thinking about the problem and 5 minutes thinking about the solutions. And I would submit to you that perhaps the way we think about the problem is not accurate. It's not perhaps about, points of mammogram rates and other sort of quality metrics, but it's more significant and more global than that. And Atul Gawande captured it well. The medical system had done what it so often does, perform tests unnecessarily to reveal problems that aren't quite problems, to then be fixed unnecessarily at great expense and no little risk. Meanwhile, we avoid taking adequate care of the biggest problems that people face, problems like diabetes, high blood pressure, any number of less technologically intensive conditions. An entire healthcare system has been devoted to this game. And that's kind of the problem, is that we have to figure out how do we start to focus on those big issues. And, I think we all sort of are in agreement, and is that MIPS and macro and sort of some of the changes that have been coming are not necessarily going to be the answer to the Atul Gawande question of how do we really improve the fundamental issues in healthcare. So I'm going to talk a little bit about some of the things that are happening that I think are going to be interesting. And one other note is that we've talked about Medicare Advantage, and I think there is a lot of interest out there, and I think there are a lot of benefits to Medicare Advantage. One thing that's of note is that this correlation, that the correlation is between the benchmark that providers get paid for taking care of patients is highly correlated to their rate of success. So this is the percent of ACOs receiving shared savings. And if you're in the lowest quartile of your payment benchmark, you're much, much less likely than those who are getting a high rate of pay per beneficiary to receive shared savings. And so what are the implications of this finding? Well, basically it says that maybe it has more to do with what you get paid in the beginning than it does with how innovative and creative and what a good job you're doing in terms of your, actually reducing the cost of care in a meaningful way. And so I think we still have work to do to work on this. It shouldn't be a factor of what you get paid in terms of how successful you are in the ACO. It should be, how creative and how diligent have you been, how engaged are your physicians in actually managing the care that should be making the difference. So we still have work to do. And part of the issue is, it has a lot to do, I think one of the themes that I'm going to touch on is that one of the keys is getting physicians engaged in the management of patients if you're really going to create value and really do good work. And this is one of the ways in which Medicare Advantage often does do well. But there are interventions that will work if you give them time, if the doctors are engaged, but not all of them have immediate impacts. So for example, up at the top here in the light green, if you work on transitions of care management, for example, which is expected to help you reduce readmission rates, you can have, in 3 months, you can see some benefit from that. Similarly, but in a much different time horizon, if you work on preventive care, screening, lifestyle changes, wellness, that's got more of a 3 to 5 year window before you will start to see payoff. So in other words, you need to have a long time horizon. You need your physicians engaged, and if you are diligent and are able to get those physicians engaged, you can see benefits, but there really needs to be a long-term commitment if you're going to create value. Let me talk about a couple of the trends. And the first one is this incremental evolution from volume to value. And so taking the fee-for-service environment and changing it to volume or to value takes some effort. So this is a graphic that just basically shows you in the commercial space, years 2017, 18, and 19, this is the amount, about 70%, 65 to 70% of the reimbursement in the commercial space is still fee-for-service. If you look at the federal plans, a lot of it is still fee-for-service. Medicare Advantage up at the top here is a good quarter of the federal spend, but even within Medicare Advantage, you still have some pay for performance and fee for service. So we still have work to do to get past fee for service, but making incremental change is what's happening, and that's going to take us some time. And why are we moving incrementally? Well, this graphic tries to give you some idea why that is. On the y-axis here, value-based contracting, and on the x-axis, population health management. Well, if you're working on your population health management activities and you're way out here, but you don't have any value-based contracts, all you're really doing is saving money for the insurer or the payer. So really, as a provider, you need to be balancing your value-based contracting and your population health management activities and expenditures and infrastructure so that you're maintaining this sweet spot here between your contracts and your infrastructure that you're building up. And so organizations typically move along in incremental. Just a note, make sure that you're on mute if I'm just hearing some feedback from other people on the line. All right. So one case example that I'll go through relatively quickly is an example from Hawaii, where there's a group that is working hard to move from fee-for-service to value. And they have this initiative called Mahie, and they basically took this from the word in the Hawaiian language that means transformation. and they've tried to transform themselves from fee-for-service to value. And I'm going to show you how complicated that is, but they're making a very good effort. They're taking their existing fee-for-service payments, and they had some payments for patient-centered medical home and pay for quality, and they're converting it into a new program that's got 80% of a base pay, 20% for engagement measures, and I'll describe what those are, another chunk based on performance, and then they're adding in some shared savings element to get the providers engaged. And I'll talk a little bit about each of those. So that first 80% is based on their previous fee-for-service reimbursement over a 3-year period. And they're basically trying to keep the providers whole so they don't get too upset. And then incrementally, they're adding in some other elements over time to phase them in. So again, sort of the base is a per member per month payment. And then they've got 20% starting in this year, 2018, that'll be at risk based on work that they've done in 2017. And this is to encourage active participation. So this is basically for engaging members through visits, calls, emails, referring patients to health programs, using some of their applications. So basically a participation element to the reimbursement. And then they've got basically a pay for performance element as well. So they're going to be measuring sets of metrics that both the providers and the payers have agreed to, more of a typical P4P type of arrangement, and that's being factored in as well. And then on top of that, they've got a little bit of total cost of care. So if the cost of care is effectively reduced by these providers, that they will share up to 40% of the savings, and the rest will go back to the employer groups, and et cetera. So you can see it's not simple. It's elegant in some ways, but it's not a simple effort to get from fee-for-service to a value-based. So the alternative is that I think we will be seeing in 2018 more providers going into the advanced payment models, so APMs, than there were in 2017. There'll be more groups looking to go into ACOs. Some of them will qualify as APMs. But you have over time had several, 100 or so ACOs drop out of the ACO program, and that's partly because there's really no sort of switch to flick on to go from fee-for-service to, from volume to value. It's been difficult to engage providers, and I'll talk a little bit more about that, and it's costly to develop this infrastructure. So one other initiative that's ongoing that Medicare has put out there is this new program called there's a new track to this program, the CPC Plus, Comprehensive Primary Care Plus. And this is right now is available only in a few locations in the United States, but they're trying similarly to move beyond just plain old fee-for-service payments from Medicare. And there are 2 tracks in this CPC Plus, and they're similar, but track 2 is the new one. And there's a care management fee, which is a per beneficiary per month payment that's basically paid to the providers to basically support staffing and training for comprehensive primary care. They're also getting basically a pay for performance incentive based on quality of care. And then in track 1, they still get paid a fee-for-service amount in addition to this upfront care management fee. But in track 2, what they're doing is upping the ante in terms of the amount that they get paid for the care management fee and the quality. But now they're starting to put in a prospectively paid comprehensive primary care payment. So it almost becomes a capitated payment that they receive on a quarterly basis upfront and based on the number of beneficiaries that they've got. So in a sense, it's taking a fee-for-service environment and trying to add in and sort of scale back on the fee-for-service piece and expand on more of a a capitated arrangement. So sneaking up, if you will, on capitation. So, and I think what we're seeing is that around the country, as BDC, as we go around and work with in population health and physician groups and hospitals, many of them are still largely in a fee-for-service environment. And so one of the questions that we often are asked is, well, we know that we need to move to value. How do we do that? It's so costly. What's the strategically smart way in which to do that? And if you look at this graphic, on the x-axis here is physician-hospital alignment, and here is the need for care coordination. If we're in fee-for-service, you don't really need a lot of care coordination, and you're not really dependent on physician-hospital alignment either, so you're stuck here in the lower left-hand corner. If you're going to go into global arrangements, and Mark actually used the term, capitation nirvana, and in some ways, capitation really exemplifies this outer quadrant here. You need a lot of physician-hospital alignment. You can't do it alone as a medical group. You can't do it alone as a hospital. You need to be aligned. Plus, you need a lot of care coordination. So you're sort of in the upper outer. Bundles, which I'm going to talk about in a minute, are also another way that basically works out in the upper outer quadrant with a lot of alignment between doctors and hospitals and a lot of care coordination. P4P and pay for quality are sort of in this range, depending on what the metric is. That doesn't require a whole lot of necessarily physician or hospital alignment, depending on what the issues are. So what we're seeing is that gradually provider systems are moving to the upper outer quadrant and trying to figure out how can we get out here safely, because this is where there's more opportunity to engage physicians and be effective in terms of delivering value. So just a couple of slides on bundles. So, perhaps you feel like I do that bundles were sort of waning, and the government is backing away from the mandatory joint replacements and everything, and that is true. But I believe, and we believe, that bundles make a lot of sense from a value point of view, and that the new program could be pretty interesting. So the new program that just came out, literally, January 9th, is called the Bundle Payment for Care Improvement Advanced. So it's the BPCI Advanced program. It qualifies as an advanced payment model later on in the macro years. It's a retrospective 90-day bundle. There's 29 inpatient diagnoses, 3 outpatient diagnoses, and open enrollment just began and ends in March. And the next time for providers to enroll in this program will be not until 2020. So I talked to one of my colleagues who works in this space in a company, and I'll show some data from his company in a little bit. And there's a lot of interest now that this program is no longer mandatory but is voluntary. There's a lot of interest out there, and so we expect to be working with programs and hospitals and medical groups quite a lot on bundles in the future. And as you remember, the bundles are interesting because they've got this nice trigger event. If you're working in an ACO or Medicare Advantage, you have all sorts of analytics to figure out, who are my patients, which ones are the high risk that I need to focus on. The nice things about bundles is that I show up at your doorstep and I say, hey, I'm here for a knee replacement, and okay, David Fairchild, you're in the bundle. It's very clear who's in and who's not, when the start time is and when the end point is. And then you've got the providers acting as sort of conductors of the orchestra, if you will, to manage the hospital, the skilled nursing facility, at risk for readmissions, what happens in home care, do they go directly to home or to SNF? And so you manage that whole 90-day episode, and you try to reduce costs and improve quality, improve your outcomes, and it's a wonderful incentive model for getting the specialists engaged, particularly in creating value. And just as an example of the degree of differential in costs out there, this is lower extremity joint replacement. And I want you to look at the green bars here. This is the average wage adjusted post-acute care costs for post-acute costs for lower joint replacement in different states. And if you're in the state of Mississippi, the average is $12,000 some, and if you're in Oregon, it's less than $5,000. And so you can see that there's a lot of opportunity here to work on, particularly post-acute care, which is very variable from state to state, location to location, and there's a lot of opportunity there. And this colleague, prior colleague of mine, who worked for a company, or works for a company called Archway, he founded the company. They work with groups who are doing bundles, and he gave me some examples of what they've been able to do with different providers. And you can see 3 different examples of different orthopedics practices. They're looking at lower extremity joint replacements, and the revenue per surgeon can be pretty impressive depending on what you can do managing joints. So again, I think there's, in this voluntary program, there may actually paradoxically be more activity and more value produced than from the mandatory joint program or bundle program. So I anticipate that there will be more interest in these bundles going forward. The next trend that I want to touch on is the consumerism trend, and I think what's happening here is that there's going to be rewarding greater access to convenient and low-cost care, and there's no question that telehealth is going to continue to affect the way we deliver care. There's just numerous examples. I don't need to touch too much on this, but both from providers and various companies who work with provider systems to deliver telehealth services around the country, around the world, ranging from, just sort of minimal acute care to more specialty-oriented virtual care. I think we'll be seeing a lot more of this as the technology improves and providers and patients are interested in it, and providers are very excited about providing it. One of the other trends that I think is very interesting, and Mark touched on this one as well when he mentioned the Optum and the that they're acquiring essentially a national company of physicians, is this whole idea of what CVS and Aetna are working on. So as you know, their proposed merger is yet to be consummated, but I think most people are thinking that it probably will happen. And it's interesting to think that what they may do. So here's CVS, a pharmacy company. They've got 9,700 pharmacy locations. They've got 1,100 MinuteClinics, and right now they do minimal amount of care, colds, and very limited number of diagnoses. But particularly as the company merges with Aetna, and now they've merged with the 3rd largest insurer who has 22 million members, this idea of expanding what MinuteClinics are and working with Aetna in terms of what they can provide and how they might incent Aetna and other insured patients to use those services, you can imagine that they're likely to start thinking about delivering more care in the primary care space, coordinating chronic care, diabetes, hypertension, things like that. It's very interesting to think that they could quickly have a nurse practitioner fleet of providers that are starting to work in essentially the primary care space. So one question I think, which is a great question, is, well, is this company friend or foe if I'm a provider? And I think the answer depends. If you are in the fee-for-service environment and MinuteClinic is now taking away your diabetes management visits and your hypertension visits and starting to eat into your urgent care business, they would be seen as the enemy. However, if you're in a value-based environment and you're worried about delivering the best care at the lowest price, and the MinuteClinic Aetna combination can deliver a good value, they would probably be in the friend category. So very interesting to think about how this will play out. And speaking of which, nurse practitioners, I think are likely to be playing a larger role for us in the primary care space going forward. And you can see in this map that Arizona, New Mexico, Louisiana, Mississippi, Alabama all have our professional shortage areas for physicians. And in fact, we've seen that in some of our clients, and I'm going to refer to one here that was in the state of Mississippi, which ranks last amongst 50 states in terms of primary care physicians per 1,000. And when we worked with them to help them set up a clinically integrated network, if you look at the right-hand panel here, when they looked at their providers in their network, interestingly, only 56% of them were physicians. The rest were advanced practice clinicians, APCs, 11% of whom were practicing on their own, had their own offices in the community. A third of them were practicing with physicians. But I think this is sort of looking ahead to the future of what primary care is going to look like, is that we're going to be increasingly seeing nurse practitioners. And nurse practitioners will work, and I think we'll see value-based models based on teams increasingly in 2018, and there are a lot of benefits to teamwork. The last one here is probably the most important, is that NPs and physician assistants will work at the top of their license, and so there are more and more nurse practitioners coming out into the market every day. Physicians, many of them are retiring, especially primary care physicians, and so there'll be a lot of emphasis in this next year and beyond in terms of how do we function, how do we work as teams, as providers, and how do we generate the most value, each of us working at the top of our license. Another interesting trend is that why not put healthcare locations where people actually want to go rather than making them come to inconvenient locations? Vanderbilt, for example, took over an old shopping mall and made it into their clinic that now does a good 25% of their ambulatory business. And where I live outside of Boston, a very similar thing is happening where the local medical group is buying up a big section of an old mall and is putting in a clinic space there. And if you can't make your location convenient and people have trouble with transportation, you can do what Geisinger is doing and using Uber and Lyft to get, as soon as you schedule your appointment, you can schedule an Uber to pick you up to get you there. So in summary, I think what we're seeing is that even in 2018, let's be clear, the majority of revenue that comes into providers is still fee-for-service. So you have to live in the middle, and you have to find a way not to get in trouble and get yourself too far out in front in terms of your infrastructure for value-based care. Nevertheless, as we're seeing, the move is still moving towards value as where the healthcare economy needs to go, and you need physicians to be engaged in order to get there. And so you'll see more systems trying to move into these advanced practice models where there's more risk and where physicians will really genuinely get engaged. I think we'll see more interest in bundles, again, where there's a good alignment of incentives. And I think increasingly there are going to be these national, low-cost, convenient provider groups that are going to be very competitive and really focused on delivering patient-centered care. So I think we'll be seeing more value creation in 2018, and I think regardless of what's happening in Washington, the move towards value is where the wind is blowing. That being said, it's not one size fits all, and I think individualizing to the individual market and where your market is the kind of thing that we at BDC do a lot in helping each individual health system and physician group think about what's the right strategy for them in this changing environment. So thank you very much for your attention.
Okay, thank you, David. And this is Claire. I'm back on the line, your moderator with everybody today. We do have, I know we're at the bottom of our time, but we can stay open for a couple more minutes if there are questions that come in. Go ahead and just as a reminder, we're taking questions using the chat. And for our audience, go ahead and click on the blue top bubble that's at the bottom left-hand corner of your screen and go ahead and submit your questions. And we'll just, wait 30 seconds or so. And while we're doing so, I'm just going to go kind of swing back to Trina and Jason if you have any final remarks you would like to say.
No, I think it was a great 90 minutes. And if anyone's interested in top issues, again, just reach out to Jason or I. We're happy to talk, to give presentations, and to send you our report.
All right, thank you. And Mark, I'm going to swing back to you just here for a second if you have any final remarks for the audience before we close out.
No, I thank them for listening to us today.
Okay. Okay, and David, just looping back to you one more time, do you have any final remarks that you'd like to throw in here?
No, great. I really enjoyed listening to the other two speakers, and I know we'd all love to hear from any questions and any contact from any of the listeners out there. And thank you for joining.
Okay. All right. Great. All right. So it looks like we don't have any additional questions. So I'm going to go ahead and take this opportunity once again to thank our speakers for joining us and all of our participants as well. We will be sending a follow-up post-event feedback evaluation form. It will come to you via email immediately following today's session. And we would love to receive any feedback you wish to share about our event. This is also another opportunity if you want to go ahead and submit a question for the speakers. We will be sure and get those in their hands immediately upon receipt. If you haven't already done so, we do encourage all of our participants to join our LinkedIn group on the web where you can post questions for a wider audience and start a discussion and also suggest topics for future webinar events. And with that, once again, thank you. This now concludes our webinar.